A very good evening to all of you. My name is Arosha Disanayaka. I'm president of the Ceylon College of Physicians. Welcome to the third in the series of Peripheries to the Fore. Just a brief word about what Peripheries to the Fore means. Now, when we set out, we thought we should learn from our peers and become better in the process. So we have a three-pronged peer learning program. We have the cutting edge series where the international experts speak to us on a very advanced or very new knowledge from very advanced resource heavy settings. Such a talk will take place towards the latter part of this month on neurology as well. Last month we had one on asthma from a very renowned expert overseas. Then we have the pearls of clinical wisdom, where we learn from our very senior colleagues. And very recently, we had a wonderful session from Dr. Anula Vijayasundara, our beloved past president, about how she produced fantastic clinical and research work during her tenure in Coronary. So this is the third, where we thought we could learn a lot, especially those who work in larger hospitals, about how our very young and dynamic and very intelligent consultants who serve the district general hospitals of Sri Lanka manage complex patient problems in resource poor settings, and then come out probably achieving the same success that somebody with higher resources would have taken. So with that in mind, we have Doctors Upul and Dr. Lakshman, who will be speaking to us about their case-based learning processes. Now, the way the country is going, even the better resource hospitals are becoming resource poor settings. So this might very well be a very good indication about how those in larger hospitals will have to manage their patients in time to come, just as somebody manages in a district general hospital. In many ways, there'll be greater health equity among patients, where everybody gets the same opportunity, greater equity. So this is a golden learning opportunity for all of us. And without any further ado, I will hand over to Dr. Rohita Amaravitane. Now, Rohita is a council member as well as the person in charge of this entire Peripheries to the Fore learning program. Rohita has put in a lot of hard work to get this program together and produce such exciting clinical material. I will hand over very happily to Rohita to actually introduce the speakers, get the speakers' speeches sorted out, and then, of course, direct the question and answer session. And also, if any of you want to leave early due to some other commitment, or if you know anyone who might be interested in listening to this program, we will be very shortly uploading this to the CCB YouTube, maybe by tomorrow. And then we will have many others joining and viewing this. So spread the message even among those who have missed so that they can come and watch it on YouTube. Over to you, Rohita. Thank you.
Thank you very much, Professor Arosha Disanayaka, for valuable introduction. Good evening, everybody. My name is Dr. Rohita Amaravitane, the moderator of today's event. Today we have third session of peer learning periphery to the fore. This is online clinical case discussion by consultants working in peripheral hospitals. We have two speakers today. They are consultant respiratory physician and consultant cardiologist. They are joining with us virtually from Trincomalee and Nuwara. At the end of both presentations, we will discuss the questions received from online audience, and please send your questions to Q&A box. Let me to introduce first speaker today, Dr. Upul Pathirana, consultant respiratory physician, MBBS Colombo, MD Colombo, FCCP USA, overseas training in Royal Brompton and Harefield NHS Trust, London, UK. Currently, he is working in District General Hospital and Chest Clinic, Trincomalee. His special interest is interstitial lung disease, sleep, and home NIV. He is going to present a case of hypercapnic respiratory failure. Over to you, Dr. Upal. Dr. Upal, over to you.
Yes, I'm going to share my screen. Good evening, everyone. Can you see my screen?
Yes, we can see.
So good evening, everyone. Thank you very much, Dr. Vitarana, for inviting us to speak in this special forum. And I thought of discussing a case of respiratory failure recently managed in our hospital, because respiratory failure is a common scenario for all the physicians, irrespective of our subspecialty. And timely interventions for this type of patients not only save lives, but it reduces the burden and cost as well. The history of artificial ventilation, as you see in this picture, has been a long journey, maybe simply mouth-to-mouth breathing for drowning victims centuries ago. The key event in this picture story I am going to relate happened in August 1952. A small epidemics of poliomyelitis were happening around the world. You can see in right-hand side number of iron lungs in Los Angeles Hospital, Country City Hospital in right side. And the epidemic was huge in Denmark Hospital, and they had only very limited iron lung. Here you can see in left-hand side, parents were weaving polio patients inside the hospital. The hypercapnia in those polio patients had been wrongly attributed to the respiratory response to metabolic alkalosis. The simple mistake they have done was they didn't look at the pH. They suspected the primary pathology in the brain, secondary to polio, the brainstem pathology causing the respiratory pathology. Therefore, they did think about further respiratory support other than the iron lung. But the mortality was 90%. It continued to be 90%. A young doctor alternatively presented a pathophysiology for hypercapnia, and that is hyperventilation and hypercapnia reflecting respiratory acidosis. And this led to an attempt of tracheostomy and positive pressure ventilation. It was a landmark, and thereafter the mortality reduced from 90% to 25%. So ladies and gentlemen, and before starting the proper case presentation, I just want to highlight that the pathophysiology is utmost important when we managing patients with respiratory failure. The things are evolving continuously. And as physicians, we are very familiar with non-invasive mechanical ventilation. And we were talking about high flow nasal oxygen therapy even before the COVID pandemic. And thereafter, with COVID pandemic, pneumonia and respiratory failure, again, we were becoming more and more familiar with high flow nasal oxygen therapy as well. So let me to introduce the patients today. She is a 78-year-old patient referred to respiratory unit for the evaluation of breathlessness and respiratory failure. She had dry cough and progressive exertional dyspnea
initially starting MMRC1 and progressed to MMRC4 over 10 years duration. There was no orthopnea, no nocturnal symptoms of wheezing or paroxysmal nocturnal dyspnea. She had excessive daytime sleepiness, a per sleepiness scale 15 out of 24 for 4 months duration, and also she had snoring. She didn't expose to passive smoking at home, and she had used only inhalers, inhaled corticosteroid, and short-acting beta agonist as required to relieve dyspnea. Her regular medications were amlodipine and atorvastatin for essential hypertension and hyperlipidemia, respectively. On examination, she was cyanosis with resting oxygen saturation 76%. Her respiratory rate was 26 per minute. There was no stridor. Lung auscultation was clear, and there was no evidence of cardiac failure. There was a systolic murmur heard over the aortic area, and the blood pressure was 168 by 84 millimeter mercury. There was no any chest wall deformity, and neurological examination, including the GCS, normal. The body mass index was 37.8. The ABG was done while patient was on oxygen therapy because the priority was to treat the patient before investigation. And here the ABG demonstrates slightly acidic pH and elevated PCO2 in coupled with raised bicarbonate, suggesting renal compensation and a degree of chronicity. This is suggestive of acute on chronic hypercapnic respiratory failure. So what is the most likely mechanism for hypoxemia in this patient? These are the pathophysiological mechanisms we have to think about in such patient. Parenchymal lung diseases like pneumonia, could be interstitial lung disease, bronchiectasis, COPD, like that. And secondly, ventilation perfusion mismatch like embolism or bronchial obstruction. And thirdly, any shunt, might be pulmonary shunt, cardiac shunt, or systemic pathology like cirrhosis with hepatopulmonary syndrome. And fourthly, hypoventilation. And these things can occur in isolation or in combination. For example, a COPD is a parenchymal lung disease, and on top of that later stage, they can develop ventilatory failure. And this is the relationship between ventilation and partial pressure of oxygen and carbon dioxide. The red line is the oxygen and blue line is the carbon dioxide. The dashed line, the vertical dashed line, is the normal ventilation. And if it shifts to the left side from that point, it is hypoventilation, which is characterized by hypoxia and hypercapnia. Therefore, hypercapnia in this patient indicates hypoventilation. And again, another thing, AA gradient, alveolar arterial gradient. AA gradient is the difference between alveolar oxygen pressure and the arterial oxygen pressure. It is calculated using an equation, and the AA gradient is not a steady state. A physiological AA gradient exists due to physiological ventilation perfusion mismatch and change based on patient's age. This patient we are talking about had calculated AA gradient around 19, which is not elevated given the age-adjusted reference was around 21. And here, hypercapnia and normal AA gradient therefore indicates that the cause of her hypoxemia is hyperventilation alone, as all the other mechanisms described in previous slide are associated with increased AA gradient. And then the next step, the cause of ventilatory failure should be identified. So, which of the following is most likely to be the cause of hyperventilation in our patient? First, COPD or other obstructive airway disease like vocal cord paralysis could be associated with ventilatory failure. or neuromuscular disease like motor neuron disease or muscular dystrophies. Chest wall deformities like kyphoscoliosis. Even our TB patients' spot disease, thoracic, the deformities in chest can cause later ventilatory failure. And obesity hyperventilation syndrome or other central hyperventilation syndrome like drug-induced or other idiopathic varieties. These are the initial blood investigation. There is mild anemia, which is unusual in chronically hypoxic patient. We expect it to be polycythemia. CRP is mildly elevated and cardiac troponin is negative. TSH is normal and COVID PCR and RAT negative. Further investigations are needed to look for the cause of hyperventilation in this lady. The chest radiograph here demonstrate apparently normal X-ray except age-related unfolded aorta. And then we did initially electrocardiogram for evidence of myocardial infarction or arrhythmia. It was only sinus tachycardia. And echocardiogram was done with the intention to look for pulmonary hypertension and also the cardiac functions. All were normal, and there was mild concentric LVH compatible with long-standing hypertension and also aortic sclerosis, which was noted during examination also. This is a study done in Colombo, and they found that approximately 1/3 of people are obese in Colombo city. Worldwide incidence is also rising. With such epidemic of obesity, the prevalence of obesity-related complications are likely to increase in future. The association of these characteristics has long been recognized, and medical texts of the early 19th century accept the association of these signs and symptoms. These co-workers in 1955 described in detail the clinical and physiological aspects of a case of obesity, polycythemia, and alveolar hyperventilation. All of the physiological abnormalities have been attributed to the alveolar hyperventilation, but an initiating mechanism for the alveolar hyperventilation was not discovered. These were taken actually from the Wikipedia. The paper of the Pickwick Club was Charles Dickens' first novel in 1836. Samuel Pickwick was the main protagonist and founder of the Pickwick Club. Joe, the fat boy who consumes great quantities of food and constantly falls asleep in any situation at any time of the day. In 1956, Burwell and colleagues compared patients with obesity associated with alveolar hyperventilation with the obese, somnolent Charles Dickens character and popularized the description Pickwickian syndrome. Joe's sleep problem is the origin of the medical term Pickwickian syndrome, which ultimately led to the subsequent description of obesity hyperventilation syndrome. So what is obesity hyperventilation syndrome? Patient must be obese, BMI more than 30, and they have daytime hypercapnia, arterial carbon dioxide tension more than 45, and also they have sleep disordered breathing. And we should rule out disorders that may cause alveolar hyperventilation like neuromuscular disease, mechanical causes like chest wall deformities, intrinsic lung diseases, and also central hyperventilation syndromes. So in that scenario, we can make the diagnosis of obesity hyperventilation syndrome. So in our patient, there was neither chest wall deformity nor neuromuscular weakness, and no parenchymal lung disease clinically and radiologically to explain hypoventilation. There was no offending drug to cause central depression. An immediate sleep study was not offered to look for central hyperventilation, and it is not practical at that time. So at the beginning, so on admission, we concluded that this lady has obesity hyperventilation syndrome. So we offered immediately the treatment with non-invasive ventilation, that is BPAP mode, in combination with oxygen therapy. We optimized the asthma treatment with nebulization, steroids, and combination inhaler therapy, and we continued her routine medications. So when we start non-invasive ventilation for this lady, EPAP was initially selected 6 centimeter water, and with that oxygen therapy, her saturation was all right. Therefore, we didn't change EPAP anymore, and backup rate was kept in 14, and IPAP was started initially from 12 and gradually increased it to achieve normocapnia and normal pH. And then patient was monitored clinically and also with arterial blood gas to normalize the hypercapnia and pH. So her arterial blood gas and the clinical improvement was marked with non-invasive ventilation and oxygen therapy. And for the first 24 hours, we gave continuous NIV. And then thereafter, on the second day, we gave alternative NIV and oxygen therapy. From third day onwards, she was on just only nocturnal NIV therapy during sleep. And after 3 days of nocturnal NIV during sleep, we withheld it and repeat APG in 72 hours. And again, we showed hypercapnia recurrence. So with that, actually, this lady, she had daytime sleepiness, excessive daytime sleepiness for 4-month duration, which could be either obstructive sleep apnea syndrome, or it could be chronic hypercapnia leading to hypersomnolence. And also on admission APG, patient had evidence of chronicity. And after withholding NIV, repeating APG, and showed again recurrence of hypercapnia. With that ground, we decide patient has a chronic problem, and therefore she is a candidate for domiciliary NIV with nocturnal oxygen therapy. We did consider daytime oxygen therapy because daytime saturation was normal. So therefore we consider her domiciliary NIV and discharge with home NIV after addressing the obesity issues as well with the help of nutritional team. And she came to clinic in 2 weeks' time, and her saturation was normal on air, and there was no any excessive daytime sleepiness. And she had markedly improved, and exertional dyspnea also improved. ABG was normal. Right. So our diagnosis, OHS, how does it occur? Obese subjects have an increased demand for ventilation and elevated work of breathing, in addition to slight respiratory muscle weakness and diminished respiratory compliance. Thus, obese individuals have an increased respiratory drive compared with normal weight patients to compensate for the increased ventilatory requirement. So here I am talking about the obesity patient without OHS, because increased demand of respiration, they have increased respiratory drive to compensate that one. Therefore, they are normocapnic during the daytime. The pathophysiology of OHS is related to 3 major mechanisms. First, obesity-related changes in the respiratory system. Second, alterations in respiratory drive. So, in contrast to normal obese individuals, OHS patients, they have reduced respiratory drive, central drive. And thirdly, breathing abnormalities during sleep. So all these 3 mechanisms contributing to OHS syndrome. The ATS document on evaluation and management of OHS is to improve early recognition of OHS and advise clinicians concerning the management of OHS. And the goal of this statement is to empower clinicians to make appropriate clinical decisions and to maintain the uniformity in the management of OHS patients. If you can remember the definition of OHS in previous slide, that is obesity, daytime hypercapnia, sleep disordered breathing, and we should exclude other causes of alveolar hypoventilation. The two tests required to diagnose OHS are a sleep study to establish the presence of sleep disordered breathing and a measurement of arterial blood gas during wakefulness to establish the presence of hypercapnia. This is another question which is addressed in ATS statement also. Should we use simple serum bicarbonate avoiding arterial puncture to diagnose or to decide on ABG? Yes, we can use bicarbonate cutoff value less than 27, decide on when to measure PCO2, but it is only in low to moderate probability patients, not in high probability patients like BMI more than 40. But we can't use SPO to decide on ABG. Again, should adults with OHS be treated with PAP, either NIV or Cpap, or not to be treated with PAP? Effective non-invasive form of treatment for OHS with PAP was first reported in a case series in 1983, even though the syndrome was identified long ago. So this is the ATS recommendation. For stable ambulatory patients diagnosed with OHS, they suggest treatment with PAP during sleep. The panel acknowledged that the patients with symptomatic OHS who have comorbidities, defined as stage 4 obesity hyperventilation in ERS, and also those who had acute non-chronic respiratory failure requiring hospital admission for NIV are the most beneficial patients. So therefore, symptomatic patients with daytime hypercapnia and also who had hospital admission for acute non-chronic type 2 failure requiring NIV are the candidate for home NIV to be most benefited. And these type of patients are the patients who have recurrent hospital admissions and they consume considerable healthcare cost, and therefore, if you prescribe home PAP therapy, their hospital admission rate is reduced, therefore the burden is again reduced. And again, ATS panel judgment say in healthcare systems where the cost of PAP is not reimbursed by a third-party payer, direct out-of-pocket expenses may pose a barrier to obtaining a therapy. This is true for Sri Lanka as well, because from hospital, we can't provide NIV machines. And patients also, most likely, they don't have insurance cover. And I overcome this problem, and I was able to find donors from overseas countries for almost all my patients who are on home NIV therapy. Another question, should adults with OHS be treated with Cpap or NIV? So there's a difference between Cpap and NIV and what we should offer. OHS is commonly treated with Cpap or NIV during sleep. And if you compare NIV and Cpap, NIV is more complex and costly. But it has advantages that increase the ventilatory support. This is a study published in Lancet in 2019. It concluded that in stable patients with OHS and severe OSA. So I want to highlight here OHS patients with severe OSA. That is, OHS patients have two major phenotypes. One phenotype is they have severe OSA, apnea, hypopnea index more than 30. And the other phenotype is they don't have severe OSA, but they have REM sleep related hyperventilation. so-called nocturnal hyperventilation. So this, according to this study, stable patients with OHs and severe OSA, NIV and Cpap have similar long-term effectiveness. Given that Cpap has lower complexity and cost in contrast to NIV, until further trials are available, it is recommended to use either Cpap or NIV in patients with OHs. So I was talking about a little bit about the OHs phenotype. OHs phenotype with sleep apnea. Severe sleep apnea occurs in less severely obese patients without respiratory muscle impairment. And they exhibit long-lasting apneas and hypopneas. And they are free of REM sleep-related hyperventilation. And they are the patients likely to benefit from Cpap. And in contrast to that, morbidly obese patients, so might be BMI more than 40, and they have significant impairment in respiratory mechanics, and they have severe hypercapnia. And if you monitor these patients with overnight transcutaneous carbon dioxide, they have nocturnal hypoventilations. These are the patients respond to non-invasive ventilation instead of Cpap. So based on the available evidence, one strategy recommended in European Respiratory Review is phenotype-based approach, where OHS patient, and we do sleep study. If patient has severe obstructive sleep apnea, we go ahead with Cpap. If responding, we will continue with Cpap. And non-responders, we will switch into NIV. And at the beginning, suspected patients with REM sleep hyperventilation instead of sleep apnea, we straight away start non-invasive ventilation. Right, another question. So we have patients hospitalized with OHs managed with NIV, and these patients should be discharged with NIV or without NIV. This question was addressed in ATS statement also. Mostly, it is recommended to discharge such patients with home NIV until further assessment is available to rule out obstructive sleep apnea or REM sleep hyperventilation. The reason this has been studied well, and if you compare the mortality, those patients who discharge without home NIV in contrast to home NIV, the mortality is higher in patients without NIV. So there's another problem for us. We didn't have the facility to test for sleep apnea, and this type of patient, this problem was overcome by finding a donor. The principal preacher of the Serevila Rachamahayare donated us apnea links. Therefore, we have now facility test for obstructive sleep apnea also. And then obesity. When we come to the obesity, obesity is a major risk factor for the development of OHs. It is absolute requirement to make the diagnosis also. The current treatment of OHs, we mainly concentrate on PAP therapy. But if we miss the management of obesity, the overall management we might be missing, because the obesity simply increases the cardiovascular mortality as well. Therefore, we should concentrate on the management of obesity as well. For patients with OHs, ATS suggests using weight loss interventions that produce sustained weight loss of 25 to 35% of actual body weight. This could be either lifestyle modification or by means of bariatric interventions. Once you offer, so initially at presentation, OHs per patients with decompensation, it might be high-risk patients for surgery, but once you offer the treatment and they are stable, they can undergo the surgery. And fortunately, we have now expertise as well for this type of surgery in Sri Lanka. And when we assessing a patient presenting de novo with respiratory failure, thought to be secondary to OHs, it is important to rule out the other precipitating factors like heart failure and infection also. So once we treat such specific diseases, we offer patients oxygen therapy and also then assess the suitability for non-invasive ventilation. So if patient is a candidate for non-invasive ventilation, we start with the EPAP as I described earlier, and then again low EPAP and gradually increasing it to normalize the carbon dioxide and pH, and we manage in this acute situation. So in summary, patients with chronic or acute non-chronic type 2 respiratory failure. So this first one is actually mainly true for acute non-chronic type 2 failure. Evaluate the precipitating cause like heart failure and pneumonia, and then evaluate to detect the underlying cause of hyperventilation, and then offers positive airway pressure therapy. Most of the time it is non-invasive ventilation, and early NIV might avoid invasive mechanical ventilation also, and then decide whether this patient need home NIV or not, and then consider weight reduction strategies. So this is my talk on this patient with respiratory failure. Thank you very much for your kind listening. And if you have any questions, you can send to my email as well. Thank you very much.
Okay. Thank you, Dr. Upul Pathirana, for very interesting and very informative presentation. We will discuss questions from audience at the end of the next presentation. The next speaker is Dr. Lakshman Bandara, consultant cardiologist, MBBS Peradeniya, MD Colombo, postgraduate training in Queen's Alexandra Hospital, Portsmouth, UK. His special interest is cardiac imaging and cardiac CT. Currently, he is a consultant cardiologist working in District General Hospital, Nuwara. He is going to talk on a case-based discussion on dyslipidemia management. Over to you, Dr. Lakshman.
Thank you. Yeah. Good evening to all of you. First of all, I would thank the organizing committee of the CCP inviting me to talk in this forum. And I straight away going to my discussion. Do our patients reach their targets? A case-based discussion on dyslipidemia management. And yeah, I start with an interesting case. This is the first case. A 46-year-old lady presented with a normal lipid profile. She's asymptomatic. And her father died at the age of 55 years, attributed to a sudden cardiac death. Her blood pressure is normal. And when you look at her eyes, you can identify xanthelasma patches over her eye. But more interestingly, so this picture shows clear images of xanthelasma, and she had some tendon xanthomatas in the just below the knee joint. In addition to that, I was able to palpate tendon xanthomatas or the Achilles tendon in both legs. So her lipid profile, it's horrible. Her total cholesterol is 400, and the LDL is about 300, and HDL is 55, and triglyceride is 160. And her liver function were normal, and kidney function is also normal. The TSH, HbA1c, and her ECG echo and exercise ECG all were normal. So what's the diagnosis? So the diagnosis is a heterozygous familial hypercholesterolemia. So we made the clinical diagnosis because we don't have the genetic assessment. Use the Simon-Bloom criteria, which is the essential criteria include the total cholesterol, which is more than 290, and the LDL cholesterol, which is more than 190, as well as the patient has evidence of tendon xanthomata. So she fulfilled all the criteria of Simon-Bloom to diagnose heterozygous familial hypercholesterolemia. So it is less likely to be a homozygous disease because homozygous people will not survive up to this stage unless they had liver transplantation or another intensified management. But there are certain differential diagnoses which can only be differentiated by genetic testing, like this beta hyperlipoproteinemia or familial like defective ApoB100 or homozygous autosomal recessive hypercholesterolemia, which all are genetically classified subgroups, but our clinical diagnosis is heterozygous familial hypercholesterolemia. But so the most important thing is in the periphery, this patient was treated by GPs or several GPs for years, and patient was on suboptimal doses of statin, atorvastatin 10, 20, and for the last couple of months, patient was not on any treatment, and there was a significant delay of referral this patient for tertiary care center. But so I'm basically discussing how we approach to treatment of such a patient. First, we have to identify risk category of this patient. Then we have to identify the treatment target and the goal. Then we have to identify the correct therapeutic options, not only for this patient. So any patient with hyperlipidemia, the key strategy is to identify the risk category, identify the treatment target and goal, then identify the correct therapeutic option or options. Well, so my talk is basically on 2019 EAC guideline on dyslipidemia management. So how we apply these patients to the guideline. So this patient belongs to very high risk category. Why? The patient has evidence of familial hypercholesterolemia. We diagnosed her clinically with atherosclerosis cardiovascular disease or with another major risk factor. So this patient had another major risk factor, which is the family history of sudden cardiac death or family history of premature coronary artery disease. So this patient belongs to very high risk category. So that is the first step we have to establish. So if the patient belongs to very high risk category, then we have to identify the goal of management. So the guideline says in primary prevention for individuals with familial hypercholesterolemia at very high risk, LDL cholesterol reduction should be more than 50% from the baseline, plus the LDL goal should be less than 55. So that is the target to prevent or primary prevention to prevent atherosclerotic coronary artery disease. Well, so in this patient, her initial LDL cholesterol is 365, so 50% from the baseline would be 182, but we can't be happy achieving 182. The goal should be less than 55. So we have to achieve whichever the target, which is the lowest target. Right. So what are the treatment available to treat this patient? So the lifestyle modification for any patients before starting pharmacotherapy, we start lifestyle modification, exercise, diet. Then we have to start statins, high intensity statin therapy, very important statins, atorvastatin, rosuvastatin, or maybe simvastatin, and we can combine it with ezetimibe. So in our settings, we have statin and ezetimibe, but ideally we can go ahead with the PCSK inhibitors, which are the subcutaneous injecting agent, which is adjunctant to high dose statin and ezetimibe. But if still it not able to control the LDL targets, then we have to go for LDL apheresis. But in our patients, we were managed to get down her cholesterol to 50 by using high dose rosuvastatin plus ezetimibe. So I'm moving to the case number 2. A 49-year-old patient with type 2 diabetes for 12 years. His HbA1c is 8.6 and his blood pressure is normal, and he's a non-smoker. His father had a CABG at the age of 52 and he's on atorvastatin 10. The patient is asymptomatic, no past history of ischemic heart disease. He was screened and negative for retinopathy and nephropathy. So this is his lipid profile. So his total cholesterol is 225 and the LDL is 145. So HDL and triglyceride is quite okay. This LDL is 145. So what to be done with this patient? So as we are going for the guideline, first we have to identify which category the patient is belong to, which risk category, whether it's a mild, moderate, high or very high risk. But so the guidelines indicate the patients with diabetes mellitus without target organ damage plus another additional risk factor belong to high risk category. Not very high risk, it's a high risk category. So this patient has diabetes mellitus more than 10 years plus another additional risk factor, which is the family history of coronary artery disease. So in that case, this patient belongs to high risk. But if the patient has diabetes for longer duration plus three additional risk factors, the patients move into very high risk. But in this case, the patient is fallen into high risk category. So if the patient is belong to high risk category, what the guidelines say is the patient is having high risk. So we have to reduce his LDL cholesterol 50% from the baseline plus LDL goal, which is less than 70. So in this case scenario, the patient is belong to high risk category, and the high risk patients, the LDL cholesterol should be half from the baseline plus we have to keep, which is less than 70. Yeah. So in this case, he's starting with the LDL cholesterol 145. So we have to achieve at least 72, and we have to maintain which is less than 7, whichever is lower. Well, we move into case number 3. A 65-year-old patient with non-STEMI presented with the following lipid profile. It does not have any other risk factors. This is one of the common scenario we encounter in the periphery. So a patient with non-STEMI coming with the LDL of 185. And the total cholesterol is 225. So HDL and triglyceride doesn't have much of concern. So what is the risk category of these patients? Non-STEMI, LDL is 185. So if anybody with a documented atherosclerotic cardiovascular disease invariably belong to very high risk. So is invariably belong to very high risk. So if the patient is having very high risk, and for the secondary prevention, because already the patient has coronary artery disease, we have to reduce his LDL cholesterol more than 50% from the baseline, plus we have to keep the LDL cholesterol, which is less than 55. So this is a clear cut case of very high risk, and LDL should be half from the baseline, and we have to keep less than 55. Right. So he started with LDL of 185, so the half would be 92, but we can't be happy if the patient is achieving 92. We have to keep it less than 55 with a high intensity statin therapy. Right. So after 1 year of medical management, the patient doesn't like to go ahead with the intervention, PCI or CABG, but patient is on medical management and he was on high intensity statin therapy, atorvastatin 40. He again presented with a transient ischemic attack. His blood pressure is normal and HbA1c is normal. So in that presentation, his lipid profile is like this. His total cholesterol is 142 and LDL is 60. Now what to be done? So the patient was on high intensity statin therapy of 40, but still he didn't achieve the therapeutic goal. The goal should be less than 55, though he has achieved 50% from the baseline, but still the statin has not done its job because we have not achieved the LDL target of less than 55. Then, what the guideline says? The guideline says, for the patient with atherosclerotic cardiovascular disease who experiences a second vascular event within 2 years. So if there's a frequent event happen within 2 years period, which is not necessarily the same as the first one, who is taking the maximally tolerated statin-based therapy, the LDL goal should be further reduced to less than 40. It should be considered. So this patient, we have to go for high intensity statin therapy plus or minus acetamide, or sometimes we have to consider PCSK inhibitors. So unless we achieve that target, so we are not fulfilling the primary goal of either secondary prevention or primary prevention, because this is the evidence-based management or evidence-based goal. Well, so I'm moving to the case number 4, which is the last case. A 42-year-old asymptomatic person underwent lipid profile as a screening purpose. So this is quite common nowadays. The people are being screened for high blood pressure, high blood sugar, cholesterol, and all the stuff. So his blood pressure is 160. over 70 is hypertensive, and HbA1c is normal, 5.6 marginal. The liver and renal functions are normal. There's no family history of ischemic heart disease, but he's a current smoker. But this is a very asymptomatic patient, doesn't have any symptoms at the moment. So his total cholesterol is 215, LDL is 140, HDL is 38, and triglyceride is quite okay. So now, what to be done with this patient? So he's a smoker and has high blood pressure. He's 42, male, and his LDL is 140. So if you go according to the guideline, first we have to identify which risk category the patient is belong to. Then we have to identify the goal. So how to be done in this patient? Because he doesn't have a diagnosis, he's asymptomatic. Well, so if I go with the charts or the guideline, so they advise us to use the SCORE risk calculation chart. So I use the high risk, the chart belong to high risk region of Europe. But I will soon discuss how appropriate is charged to our population. But according to the guideline, I'm using high risk region for Europe, which is the Eastern European population. In our patient fall into here because his cholesterol is nearly, total cholesterol is nearly 6. And the other thing is, in this SCORE chart, we use the total cholesterol, but not the LDL. So the total cholesterol is around 6 and his blood pressure is 160 and he's a male and a smoker. So his 10-year cardiovascular risk is yellow, which fall into the category of moderate risk. The risk is less than 5, more than 1. So it have a moderate cardiac risk. So if this patient is applied for the guideline, its calculated score is 1 to 5, then his LDL target should be kept, which is less than 100. So if this patient goes to the European guideline, his LDL target should be kept less than 100. But the problem is, so this European guideline use 2 SCORE risk calculation chart, one for high risk region of the Europe, which is the Eastern Europe, and the low risk region are the Scandinavian countries, including UK. But when you compare the vascular event or cardiovascular disease prevalence in the countries like Asia, which is far away, higher than the Europe. So if you use this chart according to the guideline, we are underestimating the cardiovascular risk of our patient. So in my personal belief, we should not use, because it is giving a false assurance for our patient. So what to be done? So the WHO has introduced another chart, okay, which is for people with diabetes and without diabetes. Okay, so this is a patients without diabetes, and that basically is standardized for Bangladesh, Bhutan, India, Nepal, and Pakistan. But unfortunately, we don't have data to produce this chart, so we were not included. But we have to assume our cardiovascular disease prevalence also quite similar to the South Asia. But this chart itself can't apply for the guideline because this chart is not in the guideline. And if we use our patients to this chart, he is in not the moderate or moderate to high risk category. His cardiovascular risk is more than the chart that we use for the Europeans. So best thing is to use your clinical sense, not adhering to the charts, but you can decide, okay, whether it's a patient having a more towards the mild risk or more towards the higher risk, and always give the chance of having intensified therapy considering the patient's benefit. Well, so what happened to these patients further? He was started on rosuvastatin 5 and advised to stop smoking, and he was started on dietary measures, exercise, and medications to control his blood pressure. However, patient had recurrent atypical chest pain. So if somebody is diagnosed to have high cholesterol, they are anxious, and he has these multiple pains, aches, pricking sensations, and everywhere. So he was asking for a second line test, and he was underwent a CT coronary calcium scoring. The CT coronary calcium scoring is a non-invasive test, and we are not using the contrast. It's just going through the CT scanner, and we can see how much the calcium deposition in his coronary arteries. So he had a CT coronary calcium scoring, and which showed calcium in his coronaries, which is the calcium score is 250 angstrom units. So what the guideline says. So if somebody is with a CT calcium scoring, which is more than 100, his risk will be reclassified, can be upward or downward. And if somebody is with a CT calcium scoring, which is more than 100, now he may be reclassified them higher risk category. The earlier, for the clinical basis, he's have a moderate risk. Now he has gone for the higher risk. So if the patient was diagnosed to have high risk, now we know his LDL target should be less than 70. But initially, the same patients on the clinical basis, we kept his cholesterol targets around less than 100, but now the CT calcium scoring accelerated his treatment goal to less than 70. Okay. And the same patient had, a lot of complaint, and he's very anxious. He want to know about what happened to his coronary arteries. So he underwent a CT coronary angiogram, which is also non-invasive, use a contrast, and it showed moderate coronary artery disease. No tight lesions, but only moderate plaque disease, 50 to 69, calcific stenosis on the LCS, and 50 to 69 mixed, that is calcium plus non-calcium plaque disease in the mid-RCA. So none of the lesions are critical, non-flow limiting, and prognostically also, it is quite less likely to give a immediate heart attack. However, the guideline says if the patient has moderate coronary artery disease or the plaque burden, which is more than 50% in 2 of the arteries, the patients again reclassify into very high risk. So the same patient, now his LDL target has gone less than 55. And we have to reduce his LDL cholesterol half from the baseline as well. So this is the same patients going on different investigations and modulating his LDL target. So the important message is, if we are not achieving their proper LDL target, the purpose of primary prevention will not happen. That is evidence. So the patient is liable to get atherosclerotic coronary artery disease, even though the patient is on statin. So that is the evidence says. Well, so what is the value of CT coronary calcium scoring here? So I discussed, if the patient has moderate cardiac risk, was accelerated into or graded up into high risk. That's the same thing can happen the opposite way. So if somebody was diagnosed to have moderate cardiac risk and eligible for statin, and if you do a CT calcium scoring, and the calcium score is 0, the prevalence of having a vascular event in next 10 years is extremely low. So in that case, you can defer starting statin, and it's sometimes cost effective rather than giving statin for patients without any calcium, but having a moderate cardiovascular risk. So that's the guideline guide us. So the CT calcium scoring can use to accelerate treatment as well as to defer treatment. Well, so those are my cases, and I will just touch upon some controversies by giving lipid management and using statins. First thing is whether we should have a fasting or non-fasting lipid profile. So the guideline says, so if the patient, if you want to screen a patient or person, the non-fasting lipid profile is enough. You don't need to have fasting. Why it comes? Because you will understand, to do a fasting lipid profile is extremely difficult. Even for a consultant, if you want to do a lipid profile, none of them will come with fasting. Okay, so because they have busy schedules and also it's quite difficult to get a fasting lipid profile. So what happens? They will not do lipid profile at all. So the guideline says, if you want to screen, do a non-fasting, that is have an equal yield than the fasting. Then how long we should wait to see a therapeutic response by using statin? So some people wait for 3 months, but not. So you can wait only 1.5 months, or the 6 week is enough. For an example, if you are going to treat with a patient with very high risk, you have to quickly take the LDL down, and LDL should reach their targets. Otherwise, again, there's a tendency to get another vascular event because we are not fulfilling the primary target of secondary prevention or maybe the primary prevention. So you should not wait more than 6 weeks. You can repeat your lipid profile. Then should we want to monitor these ALT ASTs continuously? No, the guideline says the clinically significant ALT elevations with statin was quite rare. So in that case, you take a pre-test sample. So after that, there's no need of routine or continuous monitoring of ALT, AST while on statin, especially moderate intensity statin. But if you think about if the patient is on high intensity statin therapy and patient with mildly elevated liver enzymes before starting statin, then you might do, but not need of routine tests. Then the diabetes. Should I get diabetes while on statin? Yes. So there's a tendency to develop type 2 diabetes mellitus if you are on high intensity statin therapy. But you should not be afraid because the statin do a lot of better than the harm. So our patient should be educated on that risk benefit, as well as if the patient has other risk factors to develop type 2 diabetes, then you should be cautious. Then the myopathy. So a lot of GPs are quite worried if the patient's CK is elevated. So the guideline says no need of routine monitoring of CK if the patient is on statin, even in high intensity statin therapy. And you can wait less than 10 times of upper limit of normal if the patient doesn't have symptoms. But if the patient have symptoms, you have to be cautious. And if the patient have asymptomatic elevation of CK, we should not be, try to take the statin out, but always there are other options, like we can reduce the dose, we can change the type of statins, and sometimes we can give every other day or weekly, like a lot of options available. So it is not an indication to take the statin off, but we have to modulate the statin. Then how much can be done with the lifestyle modification? So this is basically, I'm talking about the LDL, but not the triglyceride. So you can get down the triglyceride, quite drastically if you do weight reductions and exercise and diet. But for the LDL, the guideline itself say the change in the diet will not do much on reduction of LDL. Same as the body weight reduction as well as exercise. So exercise, diet, and body weight reduction has quite a small effect on LDL reductions. What we have to do, but we can't rely on this to get down the LDL. So we have to go for pharmacotherapy. But for the triglyceride, yes, we can do a lot of things on this lifestyle modification. Well, what about the hypertriglyceridemia? But I didn't discuss hypertriglyceridemia in this topic, but I basically focus on LDL targets and how to achieve targets. But I have seen in a lot of people, in a lot of GPs in the periphery, if the triglyceride is high, they start fibrate. But there's no indication to start fibrate for always statin. So if the triglyceride is high, you always start statin. And if the LDL target has achieved, then you can combine with 3-omega fatty acid. But if if it's not achieved, but if the LDL target has already achieved its statin, then you can consider fibrate. But always you have to be started with statin. Well, so what's the take-home message? So if you want to start statin for primary prevention, the evidence says we have to achieve certain therapeutic goals. So unless we are reaching that therapeutic goal, we will not fulfill the evidence-based approach to reduce the primary prevention, or to prevent a second heart attack or a cerebrovascular accident. So if you find any patient, first we have to identify which risk category the patient is belong to. It can be mild cardiac or moderate risk or high risk or very high risk. So depending on the risk category, the guideline gives or guideline guide you what should be the targets of LDL goal. It can be 116 if it is a mild 10-year cardiovascular risk. It should be less than 100 if it is a moderate 10-year cardiovascular risk. And if it is less than 70, if it is the high cardiac risk, and it should be less than 55 if it's a very high cardiac risk. So the patient with the high and very high cardiac risk, before achieving these goals, we have to reduce their LDL target, LDL level by 50%. So that is for the primary prevention. But for secondary prevention, they have already had a heart attack or a cerebrovascular accident. So to prevent a second attack, we have to keep them less than 55 because almost all are very high risk. And there are some categories of people who are called extremely high risk, where if they have multiple vascular event in a period of 2 years, then we have to reduce their LDL target even less than 55, which is 40. So unless we achieve this target, we will not fulfill the primary or secondary prevention targets. So that is my take-home message. When you see a patient, do 3 things. First, you identify your patient to which risk category, then identify the goal, then identify what intensified statin therapy that you are going to do, whether it's a mild intensity, high intensity, or very extremely high intensity statin therapy. Thank you.
Thank you, Dr. Lakshman, for very interesting and informative presentation. And next is Q&A session. We have received one question from online audience. These questions go to Dr. Upul. Dr. Upul.
Yes.
Yeah. The question is, don't we need to do overnight oximetry to decide overnight oxygen therapy?
Yes, what happens is in acute management, we offer non-invasive ventilation and oxygen therapy. And then once the patient is stabilized sexually, if patient has desaturations, it could be apneas, hypopneas, or REM sleep related hyperventilation. So what I did was I allow patient to stabilize and then off oxygen, and while on NIV did the sleep study polygraphy to look for it. And so then while on NIV, there was no desaturations and thereafter discontinued oxygen therapy. So it should be the way, rather than simply doing the overnight oximetry. So we can do simply overnight oximetry in subacute situation, but once stabilized, what we can do is either full sleep study with or without transcutaneous carbon dioxide monitoring overnight.
Thank you, Dr. Pur. And yes, so we have come to the end of the session today. First of all, let me to thank 2 speakers, Dr. Upul Pathirana and Dr. Lakshman Bandara, for accepting our invitation, and also for their excellent presentation today. Let me to thank CCP staff, audiovisual team, Mr. Nalina, and sponsors, Mark Pharmaceutical, for their valuable support. Also, I would like to thank all of the online participants, and next session of peer learning periphery to fore will be held on 7 August 2022. Thank you.